the event again. This conference is organized by ASIJ-Tokyo iGEM, a club at the American School in Japan. iGEM is short for International Genetically Engineered Machine and is the largest synthetic biology club in the world. This year, our project titled ESPA aims to explore an efficient method to secrete PHA out of E. coli to make bioplastics an efficient product in the market. To encourage students to further explore the realm of science, we're excited to continue the guest speaker series, where our speakers will be discussing ethical considerations in medicine. Before we begin, let me give you a broad overview of the conference agenda. We have 2 guest speakers today, October 6th, and 1 on Sunday, October 8th. Each speaker will speak for about 15 to 20 minutes, followed by a short Q&A session. We request you to save your questions for the end, and everyone, please turn on your cameras as a courtesy to our speaker. Please also mute your microphone. Now with that, please join me in welcoming our first speaker, Dr. Ali, Associate Professor of International Health at Johns Hopkins Bloomberg School of Public Health University. He will be speaking on informed consent on research.
Great, thank you so much, Akshay, for the kind welcome and introduction. And hi, everybody. It's nice to be here with you. It's a little after 7 a.m. in the morning here where I am in Baltimore, Maryland, in the U.S. And I'm very familiar with the alternate universe of having to interact across different times of the day. Much of my work is in other countries around the world, including in Southeast Asia, where I find myself every so often in Kuala Lumpur, and often I'm on Zoom late at night or early in the morning. So it's great to be with all of you and to talk about this topic of informed consent. I'm going to focus mostly on the application of informed consent in the context of research, but as you hear, it comes up in many other different contexts as well, of course. So let me jump right in and begin with the second part of that phrase, informed consent, and talk a bit about consent. So I think many of you are well familiar now with this word, consent, and how we use it in different contexts. So on the screen here, you can see a basic image that just describes a little consent scenario, which we're all probably very, very familiar with. And somebody asking another person if they can borrow their pen for a sec, and the other person says, sure. So we may not think of that as a consent interaction, but it is. And there are many, many, many other types of interactions that we have in daily life that involve, in one way or another, a consenting action or interaction. Many of those times we are giving our permission if we're the person who's being asked. We're giving our permission verbally. But sometimes in life we give our permission in a written form or other formats, depending on how formal that process it needs to be in the context. So let me just start with that the idea that consent is a very context and culturally kind of embedded thing. It's something where it looks different in different contexts, and sometimes it's more explicit and more formal, and other times it's more informal and you could say sort of implicit. So if I walk up to somebody with my arms open and they come and give me a hug, right? It's sort of an implicit consenting interaction there where they've agreed to engage with me in that kind of fashion, and I've signaled through my opening my arms that that's what I'm asking. So it is a nuanced thing sometimes. In research, we tend to make it a little bit formal and structured, and oftentimes written and with a signature and those kinds of things. But consent also comes up in other contexts, as I said, including in medicine and healthcare. So if we set aside for a moment research, which is the process of learning about the effectiveness or safety of some sort of intervention or action that we take with sub-products or with human beings or with animals, So if we set that aside for a moment and we talk about just everyday medical care and practice where people get treated for conditions that they have oftentimes in a hospital or a clinic, there also is this concept of consent that has emerged in the United States over a number of decades, and primarily did so through our legal system. So we have a series of laws and of decisions that were made and articulated by judges in the United States through cases that over years developed this concept of consent as a legal mechanism, a legal concept. And so you can see on the screen here, one of the early famous legal decisions, in this case, Schlorndorf versus Society of New York Hospital, where the judge, Benjamin Cardozo, in his opinion, in his statement after the case, wrote this, which I'll read out for you. It says, "Every human being of adult years and sound mind has a right to determine what shall be done with his own body, and a surgeon who performs an operation without his patient's consent commits an assault for which he is liable in damages." So that case was interesting. It was a case where Mrs. Schlorndorf, so again, it's interesting that in this quote he writes, every human being of sound mind, of adult years and sound mind, has a right to determine what should be done with his own body, given that the case was about a woman in this instance. But that sort of reflects, I think, the language that was used at the time. But Mrs. Schlorndorf was going in to the hospital for a sort of diagnostic procedure at the time. And the surgeons, when they operated on her in order to investigate the condition, ended up doing a much more invasive thing and took out, I think it was her fibroids in her uterus. And she hadn't given permission for that, and it led to some complications afterwards. And she raised a legal case against the physician in the hospital at the time, and ended up winning that case, in part because her right to give permission or to say no in the context of healthcare was violated. And this was formed in this case largely. But what this case says is consent. It doesn't really, it doesn't speak to the idea of informed consent, and I'll get into that in a moment. It also, just note, has these words that are bolded here: adult years, sound mind, and we'll come back to that in a moment. The last thing I'll point out is the idea of assault. So in the context of medicine, if you don't get informed consent for an invasive procedure, the law says basically what you're doing is you're violating somebody's bodily integrity without their permission, and that's a form of assault in law. So just as much as anybody else on the street, can be assaulted, the law thinks in a similar way about a medical act when you do something to someone without their permission to their body. So that's consent in a kind of briefly in a clinical medical context. Let's shift now a little bit into the research context. So in the mid to late 1940s, after World War II, there was a trial again, but this was an international sort of trial. There was a tribunal, a panel of sort of judges that was hearing a case known as the doctor's trial. These were mainly doctors who were experimenting on concentration camp prisoners during the Holocaust. And so Jewish people who were in concentration camps during the war and who were put through all sorts of horrific things, including a lot of different experiments to try to, so that the Nazi doctors and the military personnel can learn all sorts of things about how the human body worked and reacted under different kinds of conditions. And it was very inhumane. And I'm not going to a lot of the details. There have been biographies and histories told just about those kinds of experimentations that were done. But what resulted was this trial where the doctors were convicted for the inhumane actions that they took against individuals. And at the end of that trial, there was this articulation of what's called the Nuremberg Code. Nuremberg because it was being held in Nuremberg, Germany at the time. And this is thought of as the kind of first international code of research ethics. And it was articulated again from the bench, from amongst these tribunal judges. And they started this statement. It's a very simple statement. You can find it online if you're interested. It's about 10 different points that are made in it about the rights of individuals in relation to human experimentation. And it begins with the idea that the voluntary consent of the human subject is absolutely essential. So they recognized that none of those individuals were given an opportunity or any kind of say in what was done to them, and that was wrong. And a lot of risks were introduced, and people were harmed, and indeed people were killed in the name of science in that context. And so it really emphasized the role and responsibility of the researcher in obtaining consent, and the importance of individuals who are being asked or invited to participate in research to be able to exercise free choice without force, fraud, deceit, duress, or other form of constraint or coercion. So over the many years since then, this kind of doctrine or concept of informed consent emerged for research and became more and more formalized, and people became more and more interested in how to do it well, so that those goals of making sure that people are voluntarily engaging in an activity that's sometimes very complicated with full information is accomplished. So when we think about informed consent from a theoretical position, we oftentimes root this practice of informed consent in a principle of ethics called respect for persons. So when you take a kind of principled approach to ethics, you usually first start with a theory, and then you say, okay, from that theory, what are some more general principles that I can extract that are going to be able to guide practice? Because bioethics is really a kind of form of applied ethics. It's taking theory and translating into practice settings. So to do that, you have to kind of take these steps conceptually into a position where you can then say, here's some way to operationalize or put into practice settings this concept. So as we worked our way from theories to principles to practices in the context of consent, we found scholars who wrote about this in the 1970s and 60s, rooted this idea of informed consent and this principle of respect for persons. So we're demonstrating our respect for individuals, and as you can see on this page, their autonomy or autonomous decision-making by giving them an opportunity to understand and agree or not to participation in research. So autonomy just means, if you haven't heard of that word before, it's this concept that individuals should have a right to self-determine what happens with them. You know, they have interests, people have interests, and they have priorities, and they have values, and people should be able to make decisions in their life that more or less align with those priorities and values and interests. So individuals should be given with sufficient information about a potential research project under circumstances that allow them to consider those values and interests and make an informed decision. And that avoids the possibility of using people like so-called guinea pigs, right, where they are enrolled in a research study against their better judgment or interests. So when we operationalize this, think about it, what does this mean in practice? What do I need to do in order to obtain an informed consent? We have to usually satisfy these kind of four pieces, these four elements. Number one, the person who you're approaching and asking for their permission to participate in a research study has to have the capacity to provide consent, or the ability. So people who are, this could be like the cognitive capacity, or it could be the legal sort of right to provide informed consent. So cognitive capacity, would mean something like if somebody had a mental disability that prevented them from being able to consent, for example. I'm not generalizing, not everybody who has mental disabilities is unable to consent, but there may be some individuals who are unable to fully understand and consider information in a way that allows them to provide informed consent, or legal rights. So in most countries around the world, individuals who are above the age of majority, which is usually 18 years or older, have a legal right to consent to things, like in terms of contracts and those sorts of things. And so that capacity begins from a legal perspective when somebody hits that age of majority. And there are a lot of other things that can reduce people's capacity to provide informed consent. So we start there. What if we determine, and I should have said, there's an assumption that individuals have capacity. We start with that. Unless there's some kind of objective reason to begin to question it and investigate that capacity further. But we assume first that individuals have capacity. And then there's disclosure, which is really the explaining part, right? So you're telling people, what is the purpose of the research? What are the procedures that they're going to have to follow? What are the risks that are associated with the research? What are the potential benefits? What alternatives do they have other than joining the research study? You're informing them that their choice is voluntary and they can choose not to do it. And they can choose to withdraw themselves from the research study if they want to. And you're telling them other pieces of information, like where to go with questions and what happens with the data and all sorts of other things that are relevant to the study in any particular case. So you're explaining that to individuals, and you're doing it in a way, ideally, that supports comprehension or understanding. So you're explaining it to people clearly and in words and language that they can understand, not in sort of highly technical scientific terminology that only a few people know, but in ways, again, that people can understand enough to be able to consider that information, again, in relation to their own values and interests and priorities and that sort of thing. And then the last piece is authorization. So the actual agreement. So people saying, yeah, I understand and I'm okay with going forward. And they do so voluntarily, again, without any kind of force or anything like that. So that's the concept of informed consent. I'm just going to share a few more slides and then we can have a bit of discussion. This is an example of a research consent form that I just pulled from a project we were doing. And as you can see, this is a clinical research study. The words are way too small to read. I'm not expecting you to read them. But the point is that these things can sometimes get pretty lengthy and complex. And I've seen some that are much longer than this. I've seen some that are shorter. But you're oftentimes trying to communicate a lot of information to people. And again, some of that information can be fairly complicated. And even if it's not complicated, it's just a lot of information. It's hard to take that in sometimes when you're in a position where maybe you had a new diagnosis for a disease and you're under a little bit of stress in trying to deal with that. And now you're approached to see if you want to participate in a research study. So consent is not an easy thing to do well. And that's why we often think of it as a process and not an event and not a form. So the ideal for consent, for informed consent, is that you continuously work at informing and clarifying and providing people with information at the beginning, before you enroll them in the study, and at various other times where you have an interaction with them throughout the course of the study. Because people forget things, people don't understand things the first time, and to put too much emphasis on the form and the initial event makes it feels like a contract, and it's not meant to be that way. It's not meant to be something where it's like, here's everything you need to go. You sign on the dotted line, and you have no other option going forward. You're stuck, So that's not the spirit of consent, and we're trying to really move it towards being a more long-term sort of process across the life of the research study. So let me ask you a quick question. That's all right. And put it here for you to maybe add just quickly, if you'd like to, a couple of thoughts that jump to mind for you when you read this question. So that is, what or who might influence your decision to participate or not participate in research? So I talked about informed consent being rooted in this idea of respect for persons and autonomy. And sometimes when we think about autonomy, we think about, I'm on my own making a decision based on my own values and interests and things like that. But we know that's not how decision-making always works, right? We turn to other things, other people, we read things, right? We talk to people we trust. And there may be all sorts of other kinds of influences around us on our everyday decisions that we make, including our decisions on whether or not to participate in a research study. So I'm just inviting you, if you want, to put in the chat some things that you think might influence your decision to participate in research if somebody approached you to ask you to participate in a research study. Great. So actually wrote, if the research is safe or private, so he'd think about, what's the nature of the research itself. Great. Shriram saying, the family or culture could be an influence, religion. Yep. Others saying families, concerns. Good. Yeah, so you're welcome to keep writing if you'd like in the chat. Ask my parents first. Great. Good. Culture, morals. Yeah. Just to pick up on Hiro's comment about asking my parents. So we do conduct research with adolescents and kids and even newborns all the time. And it's very important that adolescents and children are involved in research, because if we didn't include them, didn't include all of you in research, then all the things we did in science and medicine would be potentially tailored to adults, right? And we want, of course, medicine and science to advance in ways that also benefits kids. So we do enroll children in research. Now, you heard me say earlier that informed consent usually is something that can only be done with people who are 18 and older. So what happens with people who are younger than 18, right? So that's an important question. And we make this little distinction in our vocabulary when we talk about a research consent interaction with an adolescent, and we call it something else. We call it assent instead of consent. So we usually go to the parent or guardian and seek their permission, but then we also explain it to the adolescent in words that hopefully they will understand, and ask for their permission as well. And depending on the age of the individual, usually, that can be more or less complicated in how it's communicated. And there can be more or less role for the parents in that decision-making process, depending on the nature of the research and other things. So we do still, we don't go ahead and, like, researchers don't do research on adolescents without their permission, but it's just something that we call it something else. So that's great. Thanks for all of those. I see financial concerns, monetary reward, lots of great comments there. And I think overlaps a lot with what I've put here on the screen of the kinds of things that I know have influenced people in their consent process and interactions. And so many of you have touched on a lot of these. And I'm not going to go into depth into each one, but there are a range of things, and again, very context dependent. So some people have used this to say, maybe consent is less of an individualistic process than we think it is. That it's actually just a process that is more integrative. And some people have developed theories around this and have referred to things like relational models for consent and those sorts of things that acknowledge that in many places around the world, people make decisions not by themselves, but with a lot of influences, and that's okay. So we want to be careful though, right? We want to make sure that those influences are positive and they're not, again, overriding what people really want to do in their lives. So a couple more questions for you, and we'll wrap up. Or maybe I'll offer these and then we can come back to them if you want in the discussion. So here's a couple of, what do you think scenarios. So the first one is, should people be allowed to consent to, and then as you can see on the screen, this headline from CNN that says, thousands of people want to be exposed to COVID-19 for science. Right? So you may have heard of this early in the pandemic when we didn't know a whole lot about the virus and about the potential for various vaccine candidates and therapeutics. Lots of people are saying, sign me up, right? Around the world, there's thousands and thousands of people were saying, I'm willing to actually even be infected deliberately with COVID-19 in order for you to work more efficiently as a scientist in developing treatments and vaccines and those kinds of things. So a question for you to consider, if you haven't already, maybe you have, is whether we should allow people to consent to those sorts of things, where they're intentionally infected with something that we just don't know a whole lot about, right? At the time, we didn't know how harmful COVID would be for everybody, and how easily it might spread, and all sorts of other things. So let me just leave you with that as you think about it a little bit more, and put another scenario forward, which is this other news headline, which I pulled, which was published just a few days ago in my region, in my city. There are some doctors who transplanted a modified pig's heart into a human being for the second time in the same clinic. The first patient who received the organ died after 2 months. And this patient says, at least now I have hope. So the patient, Mr. Fawcett, who had terminal heart disease, was facing a situation where other complicated medical condition, his condition was so complicated, he was so sick, that he was rejected from all transplant programs that use human donor organs. So he said, I have nothing else to lose. Why don't you go ahead and try it? So that's another situation, just posing it there, whether we should, allow people to take these kinds of risks in the name of science and medicine, even if it means that it might shorten their life, potentially. We don't know, but potentially. And it may have other consequences, right? It could lead to human beings acquiring infections from pigs that potentially could be spread. We don't know, right? There's a lot of uncertainty here, but the question is whether we should be allowing people to do this when really, you can understand they have no other option available to them, and scientists are telling them, reputable people are telling them that, there's some promise here. At some point down the line, we may actually be able to do something like this successfully. So that's question number 2. And question number 3 is just the gene editing question. So we have technology now that allows us to edit the human gene very efficiently. And many people have been talking about this. Indeed, one scientist has done this with human beings in China. And the question is, should we be permitting, to some extent, certain kinds of editing of practices with the human genome that could affect babies indeed, and move us towards a position where maybe we're able to eliminate certain kinds of diseases from the genetic code of an individual even, before they're born. So let me stop there and just leave you with some take-home messages about informed consent. The first is that science can be complex, as we know, and some things can be very hard to communicate clearly. Some of the things, if you look at the literature, that are really known to be hard are things like explaining to people why in science we do randomization, for example. Why half of the people will get treatment A and half of the people will get treatment B, and trying to explain that clearly. Sometimes people are told that they're randomized and they still think they're going to get the best thing that's for them. Another hard to communicate concept is placebos, what they are and why we use them. So there are some things that are difficult to communicate. And sometimes people hear that they're in research and they think research equals the best thing that's available. But that's not true, right? Research is only done where we have uncertainty about whether or not something will work compared to what we are already doing and using. So there's a lot of uncertainty inherent in research. But people see Johns Hopkins, the institution where I'm from, and they see research study and they think that's going to get me access to the best thing that's available. So there are these kinds of misunderstandings that are common, and we try to address them through a consent process. And again, consent is a process, not a form. And then there are many different things in healthcare and research in life that influence our decisions. And informed consent does not mean that we have to make all those decisions by ourselves. And then lastly, just a reminder that informed consent is just one part of what helps to make research ethical. There are many other things, other principles, other ways we operationalize those principles in practice that also contribute to making research ethical aside from informed consent. So it's just one small piece, but an important one in the process. But thanks for your time and engagement in the chat. And sorry for running long. Actually, I think we did have a good discussion. I don't know if there's time still for further questions. And
no problem. We still have around a little more than 10 minutes, so we should be fine.
Okay.
I just want to say thank you for the intriguing talk. I found the examples of experiments that patients took that you provided in the end to be especially interesting. And it made me think like why people sign up for things as risky as that, like exposing yourself to COVID. Yeah, but we will now move on to the Q&A session. So if anyone has any questions, please type it into the chat box. But I saw a question earlier, and I'd like to ask you that one. Is the definition of informed consent universal, or does it change from country to state, etc.?
That's a good question. I think with those four elements that I talked about are pretty universal when people talk about consent in different contexts. But what varies is the extent to which people within so let me back up. It's been formalized and kind of standardized amongst professionals, right, in various parts of the world. So scientists and medical doctors and other people. It's practiced more in some settings and less in others. And the way in which people make decisions varies in different cultural contexts. So what you'll find, in some places in the United States is that some patients will be fairly interested and adamant about making decisions themselves. And then in other settings, including in the US, where you find people come from other cultural traditions around decision-making, they may rely heavily on, for example, the opinion of the experts in the room, or they may rely on, as others are saying, on families and sort of collective forms of decision-making. So, and in many kind of what we call sort of communitarian societies, where people are, society is structured in a way where people are much more heavily reliant on each other. Sometimes the norm is to have more of a collective decision-making process and less individualized. But in research, the international documents that have been published, the guidelines, emphasize a particular type of informed consent. And there are other guidelines that I didn't mention that have been published to guide research practice globally.
Thank you. So does anyone have any other questions? If you want to type it in chat.
I see Hiro also commented about one of the cases. Says, I think if they really believe that they want to be exposed to the virus, they should be allowed to. However, I think that they must fully be educated on the risks and implications of such an experiment before they are allowed to agree to such research, so they know in advance what could happen. Yeah, that's a great comment, Hiro. I think, that's the goal, is to be able to fully educate individuals in advance of any kind of research study. And it's the risks, again, the potential benefits, if any, right? And many times research is done without any potential for direct benefit to individuals. Research is usually about potential benefit for future people, for other patients, or for other members of society in the future. So, because learning takes time, and and we don't always get it right the first time. So it's this interesting idea, though, about whether or not an individual can freely and voluntarily give consent in that kind of context. So if you depends on how much weight you want to put on the idea of voluntariness in the context of consent. And really kind of, giving that enough attention in the context, in addition to describing the risks and implications, so that people, are able to make a good decision that aligns with their interests. There's a lot of debate about paying people in research. I don't know if folks are interested in that, but whether or not and how much to pay people who participate in research. Some of us have seen, of course, flyers that say, join this clinical research study and get $1,000 or whatever it might be. And sometimes there's a concern around that with whether or not that might compromise people's decision-making to participate and, just go into the trial because of the money and not really consider their interests, other interests besides financial interests. So lots of debate about that. Not going to have time to go into that in depth, but it's a similar kind of issue to the one where somebody's at the end of their life, and I think reasonable people can argue on both sides of it. What else do we have? Let's see. What's the concept of consent being ongoing? How's consistency in the relay of information ensured? Do you use the same person team? Wow, that's a great question. Yeah, so you usually have with a study, you have a lot of different kind of reference documents that help people on the research team understand the study. So you have the consent form, which was created by members of the research team. And so most of the people on the team will be familiar with what's in that form. And then you have usually somebody who administers that form, who communicates it with the individual. And then you have research protocols. So there are basically recipes that researchers follow when conducting their research, and members of the research team are familiar with those. And there are clinic practices and all sorts of other things. So when you're communicating about a research study, you're drawing from the consent form, you're drawing from the protocol sometimes, and sometimes things change during the course of a study too, and your team has to be up to speed on those changes. And so it's usually not the case that there's one individual who communicates consistently with the research participant. It's usually multiple people. And it's very important because of that you have everybody on the same page before you start that study, that people understand the procedures well enough that they can communicate about them effectively with potential participants. And where people are uncomfortable with that, there's an agreement amongst the team about who to refer to for those kinds of questions, whether it's the lead researcher or other members of the team. Yeah. Yeah, informed consent is a challenge in courtrooms on a daily basis, correct? Yeah. Yeah, right. So consent is also at the root of a contract in general, and oftentimes legal cases involve disputes over contracts. So that's right, that in many cases in the courtroom, there's oftentimes a debate about whether or not people intended to agree to certain things or if they intended to agree to something else. Pig heart transplant scenario. Yeah. Yeah. Right. So yeah, that's an interesting question again from Maya about whether or not somebody consent when they have no other options. I think people can consent when they have no other options. In fact, oftentimes we do that in maybe less extreme ways, but if I find myself stranded on the street in Kuala Lumpur and I have no idea how to get back to my hotel when I'm there, and I find that I have to download an app to take a Grab or something like that, right? And maybe I'm not familiar with any other method of transportation or something, like I end up agreeing to the terms and conditions of the use of that app and consenting to them because I'm in a tough spot and I have no other option. Now you could say that shouldn't be that way, that I should have more options or so whatever, but it's not an ideal example because I think I probably would have had other options, but you get the idea that every day we we do sometimes find ourselves in situations where we're constrained in the options that we have available to us, and we still have to make a decision. But I think it becomes even more amplified when talking about, the decision about maybe extending your life by a matter of a few weeks or months or even years.
We have time for just one more question.
Oh, great. I'm just gonna pick one. I don't know if you want me to pick one or go back to the last one maybe. For assent, how much responsibility do you think should lie in the doctor or the researcher versus the patient in terms of educating potential subjects to the risk? The parents, experimentation, and in other words, how much parents be able to weigh an opinion. Yeah. It's interesting that you put this as kind of a juxtaposition or a comparison between the doctor or the researcher and the parents, and not the parents and the child, because sometimes that comes up as well, where maybe the parents want something and the child doesn't. The parent ultimately is the one who is making a decision that, like, if the parent says no, the researcher isn't going to go forward. So the parent is responsible at some level for making a decision that's in the best interest of that child. And the doctor, it depends a little bit on the nature of the relationship that doctor has with that child. So if the doctor is a treating clinician, so if they're seeing the child as a patient, then they also have a special kind of duty or obligation to that child. And it's very similar actually to the kind of obligations that a parent has to the child when it comes to explaining things about the research study. So I'm not going to say one is more responsible than another in that context. When it comes to the actual decision itself, saying yes or no, that does not rest with the doctor. That rests with the parent and the adolescent or child, who can also provide their assent. But when it comes to communicating about the study and explaining it, the doctor is oftentimes going to be the person who knows the details the best, and they have an obligation to communicate that effectively, both to the adolescent and to the parent. Great. So I think we're maybe out of time.
Yeah, we're
just about.
Yeah.
Thank
you so much.
Yeah.
Again, for joining. We really appreciated you joining this call. I think we all thoroughly enjoyed your talk on informed consent. It was a lot of fun.
Great. Yeah. Well, thanks for inviting me, and you're really great questions, and I'm super impressed just that you've organized this event as well. So congrats on that, and I hope it's useful to everybody. So thank you.
Yeah, thank you. Thank you so much.
All right. Take care.
And bye.
Bye.
Thank you.
And everyone, please stick around because we have another call in 2 minutes. So we'll have a short, maybe 3-minute break. So please don't leave. Thank you. Hi, Dr. Galiatsatos. Hello. It's nice to see you.
Hello, everyone.
Hello. And everyone, I please request you to turn on your cameras as a courtesy to the speaker. Hi, welcome, Dr. Galiatsatos. Dr. Galiatsatos is an associate professor of medicine at the Johns Hopkins University, at Johns Hopkins School for Medicine, and he'll be speaking on the ethics of screening.
And this is just a casual conversation because I know you guys have plenty of questions, and I have to leave at 8:30 or in 30 minutes. So thank you guys so much for the invitation. I'm an associate professor at Johns Hopkins and a pulmonary and critical care doctor. And the conversation about screening comes up often. So let me just kind of paint out this story to you guys. I have a 52-year-old patient. They approached me in my clinic. They have smoked cigarettes for the last 20 years. And for whatever reason, they're a personal one, they have decided, I'd like to become a non-smoker. Dr. Galiatsatos, can you assist me in that journey? And fast forward about 3 years later, they've been ultimately able to achieve that, right? And I say this because, managing people who smoke, they'll quit, they relapse, they quit, they relapse. But 3 years later, we really hit a successful gap. And in that time frame, they realized the management around their heart disease, with their cardiologist, it got better, right? Their blood pressure meds were reduced. Some of them came off. Their diabetes management got better, right? No longer on insulin. And a lot of this was attributed to how much smoking was influencing this. So now they come into the lung doctor's office and they say, Dr. Galiatsatos, I've seen improvements in my heart. I've seen improvements in my diabetes. What else should I be worried about what smoking was causing to me? And so here in the United States, one of the big things we do with screening is screening for cancers. And to be screened for a cancer, you need two things. Two things you need: the right age, and you need to have the organ. That makes sense. So for the people that we send off to get mammograms for breast cancer, certain age, 40 and older, well, depending on whose guidelines you read, and you need to have excess mammary glands. If you want to get screened for colorectal cancer, you need to have a colon then around 50. Maybe we'll go a little younger. Prostate, same thing, right? So to screen for cancers, you need the right age, because we recognize cancer is more likely, more prevalent as we get older, and you need to have the organ. So then what do we do for lung cancer, which is the #1 cause of morbidity and mortality in the United States? So I'm telling you, the cancer in the United States that causes more loss of lives, right? More lives lost is lung cancer. The cancer in the United States that is the most prevalent is lung cancer. Not breast, not colon, not prostate, is lung cancer. My dermatologist will tell me, well, we have cancers too that are higher. I'm like, okay, fair enough. Sit to the side. So what do we do, right? Because I'm saying this out loud to you all, because my patient's asking of this as well. He's 52, smoked for a good portion of his life. What does he do? And so lung cancer screenings are available for him, not because he has lungs and of a certain age, he's 50 and older, but because he is a smoker, person who smokes. So lung cancer screenings in the United States only apply for not just the age and having the organ, but also having another risk factor. So this is where we get murky. This is where I have this conversation about screening. So I'm enjoying some coffee here as well, so sorry about that. So in regards to screening for lung cancer, right now, as of 2023, the best that we have is what's called a CAT scan, a X-ray of a three-dimensional organ. That's it. That's what it is. And by the time your lungs have hit 50, you all are very young here, so you're nowhere near that age, but when you hit 50, your lungs have seen some things, right? For those of us who are older, I'm going to give you an analogy. If I did a skin exam from head to toe, I'm going to find some bruises, I'm going to find some scars, maybe some wrinkles. Your skin's going to have some abnormalities because it too has weathered the storm of your everyday use. Lungs are the same way. They're in constant contact with the environment. You breathe in, as you guys are breathing in right now. You may be breathing in some mold, maybe breathing in some dust, some poor air quality. Your lungs will breathe it in, they'll handle it, they'll get it right back out. So I say this because you might be wondering, well, why is screening just exclusive for people with a certain risk factor, smoking? Because we are seeing a surge of non-smoking related lung cancers. So then my patient who came to my clinic at 53, he says to me, "Doc, what else can I be doing more for my health? My heart looks good, my diabetes is better." So I discussed with him, I think it's reasonable to screen you for lung cancer. But my other patient, now let's take it to a different approach as I'm introducing this concept to you all, never smoker, none, not a single cigarette in his life. But he had a mother who died of lung cancer, and his mother's grandfather died of lung cancer. So he's sitting in my clinic and says, should I be screened for lung cancer? He's 62. He's had his colonoscopies, his prostate checked. And so this is the debate I have a lot with my colleagues. And it's the ethics of screening. Because you may say, well, what's the big deal, Dr. Galiazzatos? You send them off for a CAT scan, and then you tell them what's going on. So here's the issue. When you send someone for a CAT scan over the age of 50, the number one finding in those lungs is an abnormality. It's going to be. I made the case. Your lungs have seen some things. They have weathered the storm. There's going to be scars in there. There's going to be what's called atelectasis, probably a little bit of the lungs collapse. Not a big deal. It's just we got the short end of the evolutionary mechanisms that derive lungs. Birds got the best ones. We got okay ones. And you're going to get what are called nodules, these millimeter-sized things that is just a term that we use. And we're like, look, it's so small, we don't know what it is, but it's there. It looks like a little circle. We call it a nodule. That's it. It could be from a bronchitis you had when you were 8 years old and now you're 62. It's the remnants of it. It could be from a recent allergic exposure in the last week. I have no idea. When we find lung nodules, unless there's a chest CT from the past, I cannot look my patient in the eye and tell him what it is. Why that's important is because it could also be the beginning of cancer. And so what ends up happening for such patients is that a couple things. Hey, we will repeat a CAT scan in 3 to 6 months. And if the nodule doesn't grow in 2 years, right? I found something and I'm delaying. I keep telling you, look, for 2 years, you're going to have to live with this thought. After 2 years, then we're 95% certain it's not cancer. You're like, well, why not 100%? Well, there's some slow growing cancers called carcinoids and they take forever. Some patients are like, no, can't you go in and biopsy it? And the answer is not really. Unless it's a very specific place in the lungs where I can go in with my camera, my bronchoscopy, can't really get to it. So the patient's like, well, other ways. Well, there is one other way. I can go and slice it out, but if I do, I'm taking some of your lungs with you. So why I'm saying this out loud to you all is of all the cancer screenings that are out there, breast, cervical, prostate, and you can make the case for dermatological as well, the cancers that we screen for, and lung. If you look at the published trials that pushed the United States Preventative Task Force to push for lung cancer screening, it's the only one that's associated with the highest level of risk. Meaning, of all the cancers that you can be screened for, lung cancer does have an associated mortality, about 1 in 270. Meaning this cancer screening could cause some death because we may have to put patients through a surgery just to prove it's not there. So the questions that I get asked for screening, the ethical conversation that I wanted to bring to this table is, do we screen patients for diseases that A, we don't know if they have the highest risk for, B, we don't have good guidance to direct them, and C, sometimes the screening presents a lot more complications than the actual non-screening itself, especially in patients who want to be talked about lung cancer. They don't have the biggest risk factor, the number one cause of it being smoking. So what do I do for these patients? And I tell you, and I'll finish here, and we can turn it over for some Q&A. The way I approach it is I make it clear to the patient there's no right or wrong answer. And this might be a cultural conversation for doctors who practice in the States. The way I approach a patient is, one, I make sure they have capacity. Are you able to take in what I'm saying to you? I don't want patients just to nod and say, yeah, I'll do whatever you want, doctor. Two, I want them to know the risks and benefits, the pros and cons. And three, this is the most important one. Whatever they choose is the right decision. In this conversation about the ethics of screening, if my patients make a decision that they feel like it aligns with their priorities and who they are, I'm fine with that. I will always tell my patients, you have all the information, you've repeated back to me. Right now, I don't even need you to make a decision immediately. This isn't that urgent. Take your time and just know that whatever decision you make is the right decision. That's how I leave it with them. That's my approach to the ethics of screening, specifically around patients for lung cancer. Akshay, you're the one who kicked this off. Is that all right for a place to stop now? And because I know you have a ton of questions and you guys can ask any and everything.
Yeah, sure. We can get right into the questions. So if anyone has any questions, you can put it right in the chat and we'll get started.
And keep in mind, I think you emailed some questions to me as well, or someone did. So you can always start off with those too.
Yeah, sure. I'll start with them. Okay, so first, I'm just wondering, like, what inspired you to become interested in this field and also get into like all the clash between ethics of screening? Like, how did you become interested in that?
Yeah, so no, it's a good question, Akshay. And I think for those of us who join the medical field and become physicians and entering the world of science, you realize pretty quickly there's so much unknown. We have insight. We know a lot of things, don't get me wrong, but there's still a lot that medicine doesn't know, and there's massive gaps there. And at the same time, as you go through learning medicine, 4 years of medical school, 8 years of training, at the end of the day, this is probably one of the few scientific fields where I constantly have to translate the science I know to a human who has no insight into medicine. And I mean that. I mean, not in a dismissive way. They may know their health personally, but they don't view it as through the lens of a physician just because of the different type of training we went through. So I have to translate it. And then I have to make sure that they understand it for what it means for them, right? Health is personal for everyone. Health and medicine are not synonymous, right? I practice medicine. I do not practice health. Health is defined by that individual person. Health may mean having a family, having a job. Medicine to me is, do you have a disease? And the absence of a disease doesn't mean someone is healthy. So what got me interested in this is just because of my journey of being a doctor, I realize that every day. Patients have their own idea of what health means. So what does my insight into their objective data, their objective body mean for them? And how do I align that? I think if there's a doctor out there that doesn't think they are in an ethical conversation every day, I would just say, you're being ignorant, my friend. You are. Every day you balance ethics. And it could be extensive, it could be small. Because every day we try to tell patients what we're concerned about. And does that concern align with them? I've met patients who've said to me, Doc, I'd rather be dead than a patient. Patient will be too much of a burden for my family. I would not like that. And so actually what gets you involved in ethics, I think, is just every physician who joins this field, everyone, especially if you all become doctors, you are going to be realizing you're going to be part of the ethical conversations every day with patients. So someone put in a question: how fast can lung cancer get severe to a point where it involves life or death? Also, does the factor influence the patient's decisions when taking the CAT scan? So there are lung cancers that can grow rather fast, and there's lung cancers that are just incredibly slow. Like if I found a carcinoid cancer in an 80-year-old, I'm like, you're going to die with it, never from it. There are some other cancers, though, that can grow rather quickly. But the challenge is how quickly. They probably still take a few years. And the other kicker, the other aspect to them is they really don't develop symptoms until they are at the stage where they're ready to cause harm, right? They tend to grow rather silently for quite some time. So that's why, for our standpoint, if we find a suspicious nodule, 2 years is how we monitor the patient. Within those 2 years, the cancer is going to reveal itself. Is it growing or is it not? Now, obviously, if we scan them and it's big already, if it's more than a centimeter, we usually discuss at this moment they need a surgery. But you got to say that to the right patient. There's plenty of people that I've operated on with 1 to 2 centimeter nodule, and it turned out to be an old scar. We just don't have the technology to differentiate the two. We have technology, don't get me wrong, something called like a PET CT and so forth, but they will still have their limitations, I promise you. So that's the challenge. Someone put in, sorry. Some patients could be scared to be screened. Yeah, no, 100% hero. I'm stopping right there. My parents are the same way. I have I do a lot of community outreach, and I have plenty of people that say, I'd rather never know, right? And that's important to recognize. We can offer this, but we're not pushing it. I can encourage it, but I'm not mandating it. It is up to the individual to prioritize that for themselves. So, for example, someone who has symptoms of bad disease could be reluctant to be screened because they may not want to know the results. Yeah, understood. And I respect that. I completely respect that. If people do not want to know, I respect that. It doesn't do me any good, because if the unknowing allows you some peace of mind, regardless of the outcome, I can understand that. All right, on the physician side, do you think it's vital to convince the screen? Do I think it's vital? No, I don't think it's vital. I'd like to encourage it, but that's the challenge, right? I'm encouraging it from a 30,000-foot view because my goal is, hey, I want you to survive. That's why I want to do the screening. But from the patient, they may hear, you're inconveniencing me. I have to take 2 hours out of my day to do this, and I have to do it every 3 to 6 months for 2 years. And if you find something, then you're going to disrupt my life. And I'm not in a position to do that. So I don't think it's vital. Others may differ. I think it's important, yes. But at the same time, you discuss with a patient the priorities of this, and if those priorities align with them. Clinics are still at a heart of business, even though our goal is to make sure that society as a whole is healthy and well suited for the future. In terms of trying to promote screening tests, how is this ethically dealt with? So I don't know if you guys have ever been to America. 3 cancers get a lot of recognition. It's October here. Everyone is wearing pink. Everyone. Breast cancer. Let's screen for breast cancer. And I get that. Fine. People want to promote it, and I think there is some good intention behind it. I can tell you, screening in and of itself is not an economic driver. Maybe the marketing for screening is, but not the screening in and of itself. No clinic is going to stay well with it. Screening does increase life expectancy. That's where the public health comes from, right? We tend to promote things from a public health standpoint if we know it adds years to your life. And that's the intention with screenings. But there's massive campaigns with breast, prostate, and colon gets a little bit of love too. Lung cancer's never had that. We try to push it. We try to promote it. But lung cancer still is rather stigmatized in society because the #1 cause of it is smoking. So people are like, you did this to yourself. So, we try to we try to destigmatize as much as we can, because people who smoke aren't villains. It's a legal thing in society. If we thought that much of tobacco to be a cruel thing, we would have asked for it to be removed. We didn't. We allow it. So we can't stigmatize people if they want to use it. So from my standpoint, there is a lot of marketing, but I can tell you it is not an economic driver for a healthcare system. And I understand, it is a business. I'm not dismissive of that, but businesses in and of themselves doesn't necessarily mean they have to be robbed of their humanity. We can maintain that. All right, let me get through some more questions. When disclosing to a patient about their indication of lung cancer, what are factors you might consider? So a couple things. Age, so 50 to 80, their smoking history, and the last one is actually their likelihood of surviving. What do I mean by that? So if I have a patient in my clinic, she has advanced emphysema, she's on 4 liters of oxygen, right? Wearing it all the time, can barely breathe in my clinic, very frail. I'm not sending her for lung cancer screenings, because even if I find something, all my invasive testing would kill her. So I take into consideration the patient's own physiology. I would tell them I'm concerned about this, and then I tell them why I'd like to not pursue it. Keep in mind, your surgeons are the same way. Your surgeons won't operate on people if they think the surgery would be too much on the patient. So that's what other things I take into account. Are there times where you feel like you know what's better for your patient, but that contradicts with your patient's decisions? And how do you feel? Yeah, a lot of times. Oh, a lot of times. So one of the other things is I'm a critical care doctor. And there's plenty of times where I am keeping a patient alive on life support. And that's the only way they're existing. That's it. And I get a family member coming in and they're like, I don't want mom to go. She's a fighter. Yeah, so I tell them, like, look, these machines are the only reason she's alive. Her body's ready to pass on, to go to the ending that we're all prepared for. Those are the hardest moments, because the family members who want to keep that member alive, the aspect of it is, I don't know what's driving that decision, because you can see their family member looks like they're obviously suffering. Those are the hardest ones, but those are also can be the most rewarding. I can have those conversations over and over again with the patients. I'll let them know at some point, nature's going to declare herself and take the individual, right, regardless of our life supportive interventions. And it's going to be even more cruel in that capacity when the machines fail. So that's probably the hardest time. The way I've just learned to deal with it is just ongoing conversation. I think early in my career, I used to get frustrated. Now, not as much, because the thing is, as long as I can try to understand where people are coming from, I can put that to ease for myself. Medicine isn't a religion, right? It's a string of objective facts that the only way I can really convince someone is if I know them and try to persuade them from that aspect. But if I can't, I don't consider that as a failure. It just means I recognize there's other more significant things that are priority to individuals than what we're discussing here. Take a few more questions. When discussing whether or not a patient should be screened for disease, to what extent are doctors able to sway how harmful is this? I mean, I think most patients come in with an open mind, like, hey, tell me. Like, I've never had a patient like, I don't want this done. But here's what I tell patients every time. I'm not here to convince you. I want you to know what exists. It is the right thing for me to do to tell you of your options. The decisions you make from that, I will stand by. Whether they're yours in agreement with mine or whether they're yours in a disagreement with mine. But because I have plenty of patients like this who show up, I'm like, look, don't forget, you qualify for lung cancer screening. And they look at me now, they're like, thank you, doc. Thank you for reminding me. I know it's your job. I know you're trying to give me all my options. I'm okay. And then they move on. I get peace of mind knowing the patient is informed, has all the right understandings of what exists as options for their health. And if they decline, I'm okay with that. I don't think doctors should try to persuade. Now, I say this 30,000-foot view. Are there certain moments that I think it should be? Yes. I was faced with that in the ICU during the pandemic, taking care of an individual from Nicaragua. He's on a breathing mask. And I'm like, I need to put a breathing tube in you. You're about to die. And he's 30. He's young. He's like, no. I don't want anything in my throat. And I'm like, if you don't get it, you're going to die. Right. And that was not getting through to him. Actually, eventually I called his wife and the priest. We had this great conversation in Spanish. We put the breathing tube in him. 4 weeks later, he walked out of my ICU. I know if I didn't go to that next step, he would have died. He was dying in front of me. So there are times that I am aggressive with a persuasion. And from my standpoint, I think it's just a misunderstanding of what this all entails, especially the ICU. Like, no one wants to be a critically ill patient. And our interventions sound cruel in themselves. I'm putting you in a medically induced coma. I'm sliding a breathing tube full of plastic about 14 inches long down your throat through your vocal cords. I'm going to have a machine breathe for you, not even on your command. It's going to be uncomfortable a lot of times. You're going to probably get delirious, no longer can pee or poop for yourself. We're going to take that over. It sounds horrible, right? But I'm doing that in order to let your body rest, to get through this acutely ill moment of life. Then to get you back to a place where we can start letting you live again. But it's cruel. I get that. So trying to persuade someone for that, it's not easy. So there are times I do become a little bit more aggressive depending on the circumstances. I believe some patients develop mental health issues after knowing about their disease. When that happens, do you think doctors' responsibility to cure that mental? So this is tough, right? Because people have anxieties over their own disease, right? There's anxiety that can be in of itself its own pathology, and there's anxieties that are secondary to that. What do I think a doctor's responsibility for the mental health consequences? I think our responsibility is to understand not just the disease we're managing, but its consequences. And the management of that anxiety sometimes takes on different forms, right? It is sometimes managing their primary disease, reaffirming to them, hey, you're succeeding, you're doing better. And through that, they gain the confidence that they're doing okay. So I do think it's our responsibility to be aware of every consequence, not just the mental health ramifications. I mean, when I treat COPD, I sometimes, depending on my inhaler, I sometimes cause bad bladder retention where patients are struggling to pee now. So I got to take care of all the complications that my treatments do. I'll take one more question, then I'll pause to see, actually, if you have anything else, because I need to jump off at 8:30 my time. When you deal with patients in critical conditions, how do you emotionally detach yourself? Julia asking the $1 million question. I don't know. I don't have a great answer. And I'm telling you this because I remember as an intern, because as an intern in America, that's the first time you really get to practice medicine. I remember at orientation being told by my seniors, here's some good stairwells to go and cry. No one will find you. And I was like, why would I cry? Oh, did I cry? Intern year. And then I remembered fellowship, because especially in the ICU, I'm around death all the time, right? The amount of times I've told the 40-year-old new mom, you're not making it out of here. Now, don't think you'll see your newborn again. And then I got to pick myself up and then I go to the next patient, right? You have to be somewhat detached, and then you find a way to kind of deal with that energy. The pandemic probably was the hardest because we had these policies, people couldn't come in. So the amount of hand-holding I did as patients took their last breath and died, with families watching through Zoom because they couldn't be there and they wanted some human being in there. Yeah, I don't have a great answer. I think my big answer, though, is you have to not ignore it. Don't ignore it. Understand it's there. Be human. Feel. Because the more, if I become too detached, then I'm too objective. So I have to be detached enough that I can maintain my composure for my shifts, but I allow myself after that to feel it, to have a way. And then you find other outlets to kind of help you move on. This is a profession that's tough because we don't win. No one in medicine wins, right? We're battling death. So I think the comforts that I try to take is, did I give everyone the respect that they deserve with their last breath that they take? If I can say that, then they usually can get me to the next moment. So with that in mind, sorry for finishing with, that was a great question, Julia. I'm going to put my email address in the chat box. If you guys want, I run a virtual shadowing where you guys can see what I do. I really just read chest x-rays with you all, do about twice a month. I just don't know if the time zone makes sense. but they're all recorded, so you guys watch them if you want. I'm just sharing this because if you're like, oh, this person was delightful, I'd like to see what more he does. You're more than welcome to join. But Akshay, any closing comments?
No, I just want to say thank you so much for joining, and we really appreciate your time. And I think we all enjoy listening and learning from you, especially your fun little stories. And I think it was super entertaining. And yeah, thank you.
No worries. No, a true honor. And if have the honor of coming back, thank you. So thank you all, and good luck this week, or have fun this weekend. Take care, everyone. Bye.
And thank you, everyone.
Thank you very much.
Bye.